Okay, this video is biological psychiatry a joke, and what do the brain synapses show? Basically, biological psychiatry took over most of psychiatry around 1980 or so. They sort of pushed aside the psychoanalysts as part of their competition. And the big difference between psychiatry and psychology is psychiatrists are MDs, psychologists are PhDs, and the psychiatrist thus has the ability to prescribe medications. And they started to, make a new DSM, diagnostic and statistical manual of diseases, from which they could then justify prescribing more drugs. And we're going to just talk about what that means from looking at the physiology of the brain. This real quick, we'll just go through a standard neuron here. Here's the cell body of the neuron where its nucleus is located with the DNA. Here's some mitochondria. A lot of the protein synthesis goes on up here. Cell body is also called the soma. These are the dendrites where the new information goes into this neuron. This is the axon where this neuron brain cell sends information out. Action potential is initiated at the axon hillock. There's lots of sodium channels at that level. This is the myelin, the fat coating, like the insulation that speeds up the conduction of the neuron. The action potential travels down to the axon terminal, opens up calcium channels. Calcium channels cause the neurotransmitter to be released. Neurotransmitter diffuses across the synaptic cleft, exerts an effect upon the postsynaptic neuron. And that's standard neuron transmission, the so-called canonical synapse that everybody learns in medical school or college neurophysiology classes. And we're going to take this to a higher level. I just wanted to make sure everybody's got this intro level concept. Okay, here's an example of a primarily dopamine synapse. The dopamine neurotransmitter is released, comes across the synaptic cleft, binds with a dopamine receptor, like a type 2 dopamine receptor. It activates something called the G protein and again exerts a secondary effect. There's two main types of neurotransmitter receptors. One is the fast receptor, ionotropic. We'll see one of those in just a little bit later. And then here's a slow type of receptor. A slow type of receptor is metabotropic, metabolism tropic. It works through a secondary messenger and is slow to exert its effects. The ionotropic is very fast, opens up an ion channel, ions flow in. Okay, so what I want you to see is when you put a patient on an antipsychotic medication, that will block some of these dopamine receptors. And if you just do it briefly, like let's say you have an extremely agitated person and you want to calm them down quickly, that can be useful, okay? But the longer you keep them on this medication, the more the synapse will induce compensatory adaptations and change things. It could change the number of receptors, it could change the rate of uptake, it could change the amount of neurotransmitter released. Plus, what we're going to see here, and one of the big purposes of this lecture video is to show you, in the real world, it's not this simple. Neurotransmission is more like an orchestra with a whole bunch of neurons interacting. The typical average brain neuron, depending on what you read, one book will say 10,000 synapses, another one will say 30,000 synapses. And the reason for that variance is because it depends what part of the brain one is looking at when you count those neurons. But just, that's a good thing. Think of that as the low side, 10,000 inputs. Okay, here I just want you to see a serotonin synapse. Everybody's heard of serotonin with regard to treatment of depression. Typical antidepressant medication is an SSRI. That's a serotonin selective reuptake inhibitor. And so that will block the reuptake of the neurotransmitter into the presynaptic neuron. So normally the serotonin synapse, first of all, from tryptophan, the amino acid, serotonin is made and then it's released in these neurotransmitter vesicles, diffuses across the synaptic cleft, binds the serotonin receptor, exerts an effect on the postsynaptic cell. Okay, and then it's taken back up, and these small neurotransmitters must be taken back up very quickly in order to regulate these synapses, to be able to fire on and off and to turn on and off quickly. So if you block this reuptake here, you'll get more accumulation of serotonin in the synaptic cleft. And that is claimed to be the benefit with SSRIs for treatment of depression. But when one looks at it more closely, you'll see there are major problems with that theory. It's not even really a theory. Okay, now here's like a really important, there's two super important slides in this talk, and this is one of them. So we just showed this type of slide showing a normal serotonin synapse. Let's say it's got 1, 2, 3, 4, 5 receptors for this amount of space on the postsynaptic neuron, and about this many, 4 in this case, synaptic vesicles with neurotransmitter in them. Okay, and it's got one reuptake serotonin reuptake transporter. Now look what happens after the person's been on the serotonin selective reuptake inhibitor for a couple of weeks. You start seeing real significant changes after about 3 or 4 weeks. The first thing we can notice, more SERT, serotonin reuptake transporters. So the presynaptic membrane is compensating, compensatory adaptations. This is a very big deal. It might release fewer vesicles of neurotransmitter. The postsynaptic plasma membrane might produce fewer receptors. So all these compensatory adaptations come into place, and the longer the person is on one of these drugs, the more likely some of these are going to be permanent, or also the more likely some of them will be difficult to reverse, and withdrawal from the drug might take a longer and longer amount of time. Now there are some times when a change in the postsynaptic membrane could be beneficial. Like with learning. This is long-term potentiation, thought to be one of the major, if not the major mechanism of memory. So here you have some synapses. We'll just show one postsynaptic membrane receptor. All right. With repeated use of a synapse that establishes a memory trace, rehearsal of something that you want to memorize or an experience you had practicing something like playing tennis or something, you'll get more receptors on the postsynaptic membrane. So when it happens for a reason, something you want to happen, that can be a beneficial thing. So I want to make a point that modifications of a synapse, synaptic plasticity under normal conditions is a good thing typically. A couple of general points about a neuron before we get to the big slide, the big climax of this talk. Okay, the brain is about 100 billion neurons. That's a lot, okay? And again, what you read, 30,000 to 10,000 inputs for the neuron. Then synapsing outward, the neuron will often routinely synapse on 10,000 different synapses, sometimes quite a few more than that. There's approximately 100 trillion synapses in the brain. Think about how complicated that is, okay? It's, orders and orders and orders and orders of magnitude more complicated than a computer. It's the most complicated thing in the whole world. Okay, about 85% of brain synapses are excitatory, most commonly with glutamate. Remember that, because monosodium glutamate has similarity to glutamate, the neurotransmitter. And glutamate is an amino acid. Amino acids can be neurotransmitters. That's another key point and relates to protein. Okay, 15% of brain synapses are inhibitory, most commonly with GABA. Okay, so that will come up later. We're not going to get into that so much. Okay, now we're just talking about the synapses. And by the way, there's always more complexity, but it's not beneficial to us, so we won't go into it. It might be interesting, but it's not beneficial to us, so we'll stick with what really matters. There's 4 main modulatory neurotransmitters, and these are called, it's typically NADs, and that's N for norepinephrine, same as noradrenaline, A for acetylcholine, D for dopamine, S for serotonin. And these tend to be sprayed over big parts of the brain to exert a certain type of effect. Like let's say you have acetylcholine being the dominant neurotransmitter in a sense of the modulators in a parasympathetic mood. You're eating a calm meal, okay? And then all of a sudden, some shocking event happens. Somebody rides their bicycle and almost crashes into your table. All right. You're like, hey, what happened? You get stressed out. You're ready to jump and move. And that's because norepinephrine is released all over your brain to put you into a physical exertion, sympathetic autonomic nervous system, a fight or flight mode. So you can quickly activate different parts of the brain. Acetylcholine is parasympathetic autonomic nervous system to rest and digest, to feed and breed. Norepinephrine is fight or flight, stress, okay? Dopamine's a different type of modulator associated with rewards, making value judgments. Do I want to go towards that thing, like walk towards a fruit tree, get something to eat, avoid where the coyotes are? Serotonin, a little more complex. We won't get into that right now, but just be aware these are modulators going all over the place. I'll show you a picture of what that looks like here. So here would be an example of acetylcholine, associated with the parasympathetic nervous system, the rest and digest nervous system. Also feed and breed is the other mnemonic for it. And it sort of releases acetylcholine all over the cerebral cortex and puts a person into that mode. It takes a lot of energy for the body to digest a meal. Okay. And here is norepinephrine, sympathetic autonomic nervous system, typically abbreviated SANS, and that's like fight or flight mode, like we just talked about. Something physical and stressed or dangerous, whatever, gets you hyped up. And again, these are working primarily through metabolism tropic receptors, coupled through secondary messengers like G proteins, for example, in the cytoplasm that can activate multiple things that last for hours. So the ion channels are a fast on-off effect, like grab a pen with your hand, all right? Whereas the metabotropic are more like handle this stressful physical event for the next 30 minutes or even longer. And they can be part of your circadian rhythms because they can last even longer, some of the other ones. Now here's something called the Yerkes-Dodson curve of stress. If you're too unstressed, you're maybe half asleep, lazy, inattentive, unfocused, unmotivated, your performance is not going to be so good. So this is performance plotted against stress level, or norepinephrine. What you really want to be is in the middle zone, when you are alert, you're paying attention, you're in the game, you're in the zone. Okay, that's ideal amount of stress for a given activity. If you're overstressed and completely distracted or afraid you're going to choke, that's suboptimal performance again. So like, for example, Socratic questioning for teaching can perk up a student that's half fallen asleep and be good for them. But for some people, they get too stressed with certain things and their performance declines. So you really want to stay in this zone as much as you can in life for your daily activities. And in my opinion, from a lot of experience in competitive sports and competitive type academic situations, the best thing to do is just be natural. I mean, and that's why I'm a big believer, you want to avoid caffeine, avoid any types of stimulants, because you just want to be your own self, your own best version of yourself, without anything else preventing your brain from functioning like it normally does. My general philosophy of health is be like Adam and Eve, but with indoor plumbing and heating, because that makes you more resilient. We'll talk more about resilience in other lectures and stuff, but by keeping your life simple, you become mentally and physically stronger. Okay, just a quick couple points. We talked about neuromodulation. We kind of went through that. Here's just showing that, pretty much a similar pattern for serotonin. Goes over most of the brain, especially the cerebral cortex. And here it is for dopamine. Again, a rather similar pattern. So these are your neuromodulator neurotransmitters. These neurotransmitters overall are not that common in the brain. I mean, glutamate's by far the most common. That's about 85% of your neurotransmitters. And GABA is more like around 20%, 15 to 20%. So those are super common. The dopamine, the systems we just talked about, the NADs, norepinephrine, acetylcholine, dopamine, and serotonin, they're these special modulatory systems that overall are uncommon, but they exert these big diffuse effects. Okay, we previously talked about sodium channels and potassium pumps, maintaining your plasma membranes. This is another reason why eating a healthy diet, you get a lot of potassium and very little sodium, which is what you want, because that enables you to handle your calcium exchanger much better. All kinds of things happen in your brain cells, and I can guarantee you, eating a plant-based diet high in potassium, low in sodium, helps all your neurons to function better, okay? Real quick, I'll just show you an example of a glutamate synapse. So this is by far the most common neurotransmitter in the brain. Depending on the source you read, in the ballpark of 70 to 85% of your brain neurotransmitters. Okay, so you release glutamate at a synapse, goes across the synaptic cleft. Initially, it binds the AMPA receptor, AMPA-alpha receptor. That functions as a sodium channel. Ionic channel, meaning that it opens up real quick. They're called ionotropic. The sodium coming into the postsynaptic cell depolarizes it, and it raises the membrane resting potential towards zero, and that activates voltage-gated sodium channels, and you get an action potential. And once the inner surface, the inner voltage potential of the cell comes close to zero, the magnesium will move out of the NMDA receptor. This is another receptor for glutamate, really sort of a coincidence detector. It will sense the polarity of the inside of the postsynaptic cell, plus it's bound externally to glutamate, also to glycine. That's why glyphosate is thought to interfere with the function of that, according to Stephanie Seneff. So anyways, when the magnesium bounces out, then calcium can come in, and calcium can activate a whole bunch of secondary pathways. And this is very delicate stuff. You don't want too much glutamate because you don't want too much calcium in there. And that's why, again, why excessive psychological stress is bad, because it increases glutamate. Excessive caffeine ingestion is bad because it increases glutamate. So in my opinion, you don't want anything that's going to give you more glutamate than you should have from what you're normally doing. And sodium affects this. You know, if your sodium potassium pumps are not working well because you have excessive dietary sodium, that'll decrease your ability to pump out calcium, and it'll predispose these cells to more anxiety, to increased cytoplasmic calcium, making these neurons hyperexcitable and hyperactive, which you don't want. Okay, here's sort of a big slide, and this is one of the key points I want to leave you with. I've drawn on this neuron all these presynaptic inputs. So here's the dendrites. You know, here's the cell body, again, the beginning of this neuron, if you will. The dendrites are taking information. Here's dopamine interacting with this dendrite. Here's serotonin. Here is GABA, gamma-aminobutyric acid, and it's right next to the axon hillock. It's going to have a powerful effect. It can also interact with the axon terminal. You can have GABA synapses on the postsynaptic neuron, norepinephrine coming into the dendrites of the cell body, acetylcholine also coming in, and you can have norepinephrine on the postsynaptic neuron. The reason why I'm showing you this is, look at this. This is what, about 1, 2, 3, 4, 5, in the ballpark of 10 synapses. That's nothing. These things routinely will have 10,000 or more inputs, 10,000 or more outputs. And what I'm trying to say is, when you mess up the function of these dendrites by SSRI medications or tricyclic antidepressants or any of these other drugs, your antipsychotics blocking dopamine, your benzodiazepines affecting your GABA receptors, you're really messing with a delicate, complex system that's like a giant orchestra, and it's going to cause compensatory adaptations on the postsynaptic membrane. And I just read, through 4 different books on neuropsychopharmacology, trying to really understand it, and every single one of them showed significant, major worsening of outcome for all the major psychiatric classifications of medicine. Antipsychotics were most rapidly the worst. All these tardive dyskinesia, tardive demented patients, these kids on these stimulants for so-called attention deficit disorder, long-term they have relatively poor outcomes in comparison with the kids that don't go on them. Depressed patients, worse outcomes. The benzos, we talked about it for anxiety, worse outcomes. The mood stabilizer, so-called lithium and stuff, worse outcomes long-term. So anyways, why does this continue? Why are so many patients, this is called biological psychiatry, treating psychiatric disorders with, they call them disorders, by the way, because they're not sure if they're really diseases most of the time. Why do these patients have such a bad outcome, and why is it that these medicines are still so frequently, they're very routinely prescribed? And, my father was a psychiatrist, and my dad was a good guy. He was nice, and my entire life, my dad never once lied to me, never once. It'd be like unthinkable for my father to lie. Okay, he was a hardworking guy, got up every morning. His patients liked him. He even saw patients in the home at that time. We weren't even allowed to answer the door because lots of other doctors' families who we knew them would send their family members to my father. And so I said to myself, then now that I'm older and I can read and understand all these journals and books for myself, I'm like, well, why was my dad prescribing so many psychiatric medications? And I think I've figured out why it happens. What happens is a drug company wants to sell its drug. That's what they do. You can expect that. And they'll typically hire a consultant at some big name university, like an Ivy League place or some other famous medical center. And then that consultant gets free vacations, gets a lot of money to promote their drug, and also to set up studies that are really, designed to make the drugs look good. Once that big prominent consultant speaker starts to promote the drug or promote a study on the drug that's really been sort of statistically manipulated to make the drug look better than it actually is, then what happens is all the average psychiatrists, they just go by the new guideline. Well, the big shot over there at some Ivy League school, he recommends it. will just do the same thing. And you say, well, why don't they open a book and study it for themselves? Well, first of all, initially, no long-term studies are done, so no one knows. That's why it's generally wise to not use any new drug unless it's been out on the market at least 10, 15, 20 years. Okay, the second thing is, most doctors, I gave a whole video about how doctors' lives, they study like crazy in medical school and really don't learn hardly anything, jump through hoops, memorize a bunch of stuff. Then they go through residency and they learn the nuts and bolts, what the guidelines are in their field, how to generate billing codes, and that's the key thing that they learn. They might do a fellowship, maybe not. And then by the time they go into practice, they're already typically in their 30s. You know, they've delayed having kids, getting married quite often as well. Now they get a job. They want to have a kid. They're up late at night, trying to let the kids sleep. At their new job, the junior people get all the shit work. They get all the night calls, and so they have to work very, very long hours. They're completely exhausted. They got no time to read. And then what happens is these continuing medical education meetings are typically a vacation in some, nice place. Go to Florida or something, right? So they go to Florida, and they just sign the attendance sheet when they walk in the morning. And then they go to the beach with their family. You got to keep the wife happy. You've been working so much. She's pissed off. Taking her for granted, neglecting her. You don't want to end up divorced. Then you end up being a divorce mule. So what I'm trying to say is most docs, in my experience, they don't read hardly anything after they're done with their residency or fellowship. Now, there's lots of exceptions. Some of them do make time and some of them do read more. But I know lots of doctors. I talk to lots of doctors. I talk to them every day. Most of the doctors I know almost never read anything. And they almost never talk to me about reading a book. The smarter doctors I know will talk to me about reading books, but most don't. And I say that because tons of times I'll ask a doctor about this, or that, and they say, oh, I haven't had time to read it. I haven't had time to read it. That's what I hear almost all the time. They're so busy. So anyways, what I'm trying to say is once that so-called expert at the big name university Ivy League place says, prescribe this drug for depression, for attention deficit, for psychosis, it just gets done. So if you're a drug company, all you got to do is buy off one big shot from a big name place, and whatever that person says, all these other ones will follow it. And that's standard. That's routine. That's the way it works. So that's because I had to reconcile. How come my dad was a good guy and he's a bright guy? How could he do such stupid stuff, prescribe all these stupid drugs? And it's even worse at kids. I mean, basically, they poison children for drug money. That's what attention deficit treatment is, okay? To a large extent. It's really disgusting how bad it is. And no one talks about it. No one knows it. I think it's good to talk about it. Go ahead. Open up the books. I've given all the references in my previous lectures on psychiatric pharmacology, but it's amazing how bad it is. So anyways, here's my point. You can't do one thing. And Dr. Klaper often says, he's a real bright nutrition doctor. He says, you can't do one thing. Once you change something with a dopamine synapse, a serotonin synapse, a GABA synapse, a norepinephrine synapse, there's well-known common medications for all these things. You then get compensatory adaptations within that synapse, and you distort the function of it. And it can be very difficult to ever come off those drugs. And in the long term, they all have worse outcomes. They all sort of gradually push towards the pharmacological equivalent of a lobotomy. And that's why I think psychiatry is the worst field in all of medicine. Number one, electroshock is like an electrical lobotomy. Number two, these pharmacology drugs, all of them, either slowly or quickly, push towards essentially the equivalent of a chemical lobotomy, okay? And they used to do surgical lobotomies related to psychiatry. They used to do endocrine lobotomies with insulin coma. It's really ridiculous. And I know some psychiatrists, and I have to say, the ones I know in general, I like them. They're nice, they're thoughtful, they're good guys. I would consider myself friends with them. But what do I think of biological psychiatry? I think it's bad. It's a partnership with drug companies to sell drugs. And their studies, from my reading of them, in my opinion, they seem quite statistically manipulated. It's not just my opinion. I mean, there's books and books and books on what I'm talking about. I've given all the references before, but they're pretty easy to find. So anyways, be very, very, very cautious. It's very dangerous to go to a psychiatrist. You could end up on these drugs and have all kinds of really severe neurological side effects, and it could ruin your life or the life of someone you care about. So be careful. I would never take any psychiatric job. Myself, I would never take any of this. I would never put anyone in my family on one of these things based on my extensive study of them. I think they're all bad. And I'm not exaggerating. I'm understating how bad I think they are. So that's it.